Well, hello and welcome to another Facebook Live broadcast with MedStar Health. My name is Mishan Carter, and today we're going to be talking about lung cancer, its risk factors, symptoms, treatment options, and the importance of early detection. I'm joined by Dr. Massimo Hebtesh, Chief of Medical Oncology and Hematology at MedStar Good Samaritan Hospital, Dr. Dwayne Monteith, Regional Chief of Thoracic Surgery at MedStar Franklin Square Medical Center, and Dr. David Perry, Chief of Radiation Oncology at MedStar Franklin Square Medical Center. We have a lot to cover today, so if you or someone you love has been affected by lung cancer, stick around, share this broadcast with your friends and your loved ones, and ask us your questions in the comments below. We're going to take some time to answer those as well. So Dr. Hebtesh, Dr. Monteith, and Dr. Perry, welcome and thank you all for joining us today. I'm excited to have this important discussion.
Thank you.
So to begin, I'd like to turn to Dr. Hebtesh. What are the biggest risk factors for lung cancer?
So smoking is the biggest risk factor for lung cancer. Smoking, especially cigarettes, accounts for 90% of all cancers which happen. The risk is approximately 20-fold, means that, compared to someone who has never smoked, in that people with just the risk of lung cancer is 1% in never smokers. And the risk of lung cancer in an active smoker is approximately between 10 to 30-fold. It depends on the number of cigarettes they smoke, but on average is considered to be 20 times higher than a never smoker. But a heavy smoker can have as high as 30-fold increased risk of lung cancer. There are other risk factors as well, which is not as big an impact as cigarette smoking, but they are still very significant, like secondhand smoking, like exposure to asbestos. Exposure to asbestos especially is important if the person at the same time smokes. It has, it can more than double the risk compared to each of them alone. Other risk factors which are less common, like exposure to radiation, like, if somebody for other reasons had some radiation to the chest and the lung was in the field, that's one risk factor. Radon is a risk factor as well. It's not as strong like others, but it's still, present. So that is important to be screened for. But in general, the strongest risk factor for lung cancer is smoking.
Thank you. And what are the warning signs or symptoms of lung cancer? What should people look out for?
So cough is the most common symptom. It's 50 to 75% of people who present with lung cancer, they have some kind of cough. Smokers usually have a baseline cough, which we call smoker's cough. But if they see any change in the pattern of cough or frequency of the cough, that could be a warning sign. Shortness of breath is also another symptom, and people who smoke and have COPD, they may already have shortness of breath. If it's any difference, if it's getting worse, that's a warning sign. Chest pain is sometimes present. Sometimes people see blood in their sputum. That's also a warning sign. Voice hoarseness. Some people feel that their voice is getting hoarse. Or some other constitutional symptoms like unexplained weight loss without any diet, without any exercise, unexplained fatigue. They could be signs of lung cancer. Bone pain, abdominal pain, if the cancer has spread to other organs or other symptoms. If unfortunately cancer spreads to brain, people may have headache, nausea, vomiting, or imbalance. So basically anything which is out of norm for someone's health, especially in high-risk people who smoke, they have to be very vigilant about it.
Thank you, Dr. Hebtesh. And can lung cancer be prevented? I presume yes, but could you elaborate on that?
Yeah, of course, it can be prevented, but the best prevention is to avoid smoking. If you are smoking, it's never too late, stop it now. The risk of lung cancer goes down. It may never get, to baseline, but it goes significantly down. A long time ago, antioxidants were tested for people who are high risk. By high risk, I mean people who smoke or former smokers. They checked vitamin A and vitamin D level in people to see if they can prevent lung cancer. Unfortunately, it didn't work. Actually, it made things worse. Those people had even higher mortality from lung cancer. So there is no pill that unfortunately I can suggest people can take and prevent lung cancer except for smoking cessation.
Thank you. Thanks for stressing that point. It's important to not smoke. So how do doctors screen for lung cancer?
So screening is very important for lung cancer because the impact of lung cancer is huge. Worldwide, lung cancer occurs approximately in 2.2 million people each year and cause the death of 1.8 million people each year. In the United States, the incidence is around 230,000 new cases annually, and it takes the lives of over 130,000 Americans actually. So the impact is huge. So that's why screening is important. Prevention is even more important, as we mentioned, smoking cessation. But for people who smoke currently or have quit within the last 15 years, they may qualify for screening for lung cancer. There are some other criteria for that too, like, the amount of smoking, it should be around 20 pack a year. I explained what 20 pack a year means. Like if you have smoked 1 pack per day for 20 years, so that makes it 20 pack a year. If you have smoked 20 packs per day for 10 years, it's still 20 pack years. So anybody who has smoked like this and is an active smoker or have quit within the past 15 years and do not have new symptoms, they can be eligible to get low dose CT of the chest once a year. So there have been 2 very large randomized trials which showed the screening helps, lowers the mortality of patients, can diagnose the cancer at an earlier stage, which is more likely to be cured. And the largest study was National Lung Screening Trial, which showed 20% mortality benefit from screening. So that's important. And people usually, the age should be between 50 to 80. It should be high risk, as we mentioned, with a smoking history. So they get their screening CAT scan once a year. And if there is any nodules which need to be biopsied or followed or do something different, the doctor takes care of it. Once that person who has smoked passes that 15-year period, if there is no abnormal lung finding, they can stop screening for that. So these are based on the newest recommendations from 2021 from US Preventive Services Task Force, that they changed and made a few changes to the screening guidelines, and this is what is recommended. Unfortunately, less than 5% of Medicare patients who might be eligible to get lung cancer screening get screened. So we need to be much more vigilant about getting screening and much more proactive to ask our doctors about it.
Thanks, Dr. Mahabtash. So once a person gets screened and if perhaps they find something, how is lung cancer diagnosed?
So the lung cancer is generally diagnosed either by screening, by patient symptoms. If a patient goes to a doctor, present with those symptoms that we discussed, they may get a CAT scan, or sometimes it's an incidental finding, like person get a CAT scan for other reasons and the lung nodule is, diagnosed. Once we see that, we go after that for the biopsy. You have to confirm the diagnosis. And then when the biopsy shows lung cancer, the next step is staging. We want to know what stage that cancer is because it predicts our treatment planning, and then we go to treatment.
Thank you, Dr. Mahabtash. So what are the standard treatment options for lung cancer?
So treatment options really depends on the type of lung cancer. Like we have non-small cell lung cancer and small cell lung cancer. There are 2 different types and the treatments are different. It depends on the stage of lung cancer. In earlier stages of lung cancer, surgery is the standard treatment, unless the patient is not a candidate. Like, for example, if somebody's lung has been damaged for from smoking or other reasons, or they have many other medical problems that does not make them a good candidate for surgery. So other options come on the table. But generally, surgery is the standard treatment. Some patients with early stage lung cancer, they still need chemotherapy after the surgery, immunotherapy or targeted therapies, or radiation. I leave those parts to Dr. Monteith and Dr. Perry to talk more about, but then we have locally advanced lung cancer. Locally advanced means that the cancer is big, has a lot of lymph node involvement, but it has not spread to far places. So they need usually multimodality treatment. By multimodality means that I mean that chemo, radiation, and surgery, all of them. Usually those patients need all of them. If the cancer is very advanced, like it has spread to other organs, then they usually need systemic treatment, but there is still roles for radiation and surgery depending on the patient's symptoms or the number or location of the areas the cancer is spread to. If those number of areas which has spread is limited, there is still some role for local treatment.
And what about immunotherapy? Is that a good treatment option as well for lung cancer?
Yes, absolutely. Immunotherapy, let me explain what immunotherapy is a kind of cancer treatment which uses a person's own immune system to fight the cancer. So immunotherapy can boost or change how the immune system works so it can find and attack the cancer cells. Cancer happens because immune system doesn't see the cancer cells as enemy. If we can change the way body's immune system look at the tumor cells, it can be very effective. Unfortunately, it's not effective all the time, but sometimes it can be really effective, and it depends on certain factors that I'm not going to go through much details about it. But it's a standard part of the treatment for all stage 4 lung cancers, and for some stage 2 or 3 lung cancers, which have a specific marker on their tumor cells called PD-L1. And it significantly improves the outcomes, not on everyone, but in a lot of patients.
Okay, thank you. And are there any clinical trials available for lung cancer? And if so, who would be a good candidate?
So yes, there are many different clinical trials available for lung cancer with different objectives, different protocols. It can be about how we are going to combine or sequence different modalities like surgery, radiation, chemotherapy, immunotherapy, targeted therapy. Usually clinical trials are designed for a certain population, like for certain stages, for stage 1, 2, or 2 or 3, or 3 or 4. For example, stage 4 lung cancer, there are many clinical trials examining novel medications, novel treatments, and a lot of new treatments are in the pipeline. But the best way to know if you are eligible for a clinical trial is to ask your oncologist to search for a clinical trial for you, because it has many inclusion and exclusion criteria. It depends on the type of the cancer, the stage of the cancer, what treatments you have got before, or what you are looking at.
Thank you, Dr. Mahebtesh. At this time, I'd like to welcome our viewers again. If you're just tuning in now, thank you for joining us. Today, we're talking all about lung cancer, its risk factors, symptoms, treatment options, and the importance of early detection. I'm here with Dr. Masima Mahebtesh, Chief of Medical Oncology and Hematology, Dr. Dwayne Monteith, Regional Chief of Thoracic Surgery, and Dr. David Perry, Chief of Radiation Oncology. We have more to talk about, so keep watching, share this broadcast with your friends, give us a like to let us know that you're here, and share your questions and comments with us below. We're going to take some time to answer those. And I think that's a good segue to one of our audience questions. This one comes from Sarah, who was asking, what about the effects of vaping? I'll present this to all of you on the panel. Does vaping have the same effect as smoking on your lungs? Can it, is it a way that, people could easily, long-term develop lung cancer in the long run? What about that?
So vaping, the studies which looked at vaping and the effect of lung cancer, it has some adverse effects on the lung. but it has been confounded by the fact that many of these people smoke at the same time. So it has been very hard just to tease out people who only vape. And it has some nicotine to it, so it has some adverse effects. But to measure exactly how it's going to affect individually without any other effects around it, it has been difficult.
All right, thank you, Dr. Mahabtesh. So at this time, I'd like to continue with a few of my questions. So at this time, I want to turn to Dr. Monteith. What types of surgical treatments are available for lung cancer?
Sure. So the surgical treatments for lung cancer are pretty much removing the cancer and how much of the lung we have to remove. So it comes down to the standard of care, which is what we call a lobectomy. You have 3 lobes on the right side and 2 lobes on the left side, and the lobectomy has kind of been, the time-tested best treatment for lung cancer, meaning taking out the lobe of the lung that has the cancer. There have been pretty much advancements made in what we call segmentectomies, which is instead of taking out the entire lobe of the lung, taking out a subsegment of that, what we call a sublobar resection. And then, in extremely rare cases, but I think a lot of people tend to think is the common case is what we call a pneumonectomy, which is removing the entire lung. But again, that's extremely rare and typically less, we would have to remove less of the lung than that. Lung sparing is, something we take very seriously.
Thank you. Now, is surgery typically a standard part of treatment?
Yes. So I'll put an asterisk on that. So, just based on lung cancers, unfortunately, over 75% of lung cancers are diagnosed at an advanced stage where sometimes, or a lot of times surgery is not an option. For that remaining 25%, yes, surgery it's generally the primary option, but there's more and more evidence showing that some combination of chemotherapy, surgery, immunotherapy, and radiation therapy, may be beneficial.
Okay, and what about minimally invasive surgery? Is that an option for lung cancer as well?
Sure. So there are actually really 2 forms of minimally invasive surgery for lung cancer. So the more common one you may see is called VATS, which is just an acronym for video assisted thoracic surgery. It's an ugly acronym for what pretty much is the equivalent of laparoscopic surgery in the belly, arthroscopic surgery for your joints, and so on. And then the other form of surgery is robotic surgery, and some have tried to use the abbreviation RATS, which is even a more horrible abbreviation. So I tend to shy away from that, but that's another option.
All right. So you talked about you mentioned robotic surgery. So I'm assuming that is also an option offered for lung cancer.
Yep.
Could you delve a little bit more into that?
Yes. So so we offer robotic surgery at MedStar, and robotic surgery really is surgery that's not done by a robot. A lot of people think that there's a robot in the operating room doing the surgery. It's just it's robotic assisted, meaning that the robot is a tool that allows us to do the surgery through smaller incisions, typically about 3 incisions, about ½ inch each, and maybe sometimes a 4th incision, just big enough to get the cancer out. So there are definitely some benefits of robotic surgery over the other options, which is less tissue trauma, less pain, shorter hospital stay, faster return to normal activity, lower blood loss, and decreased scarring. So it's a really revolutionary advancement in thoracic surgery. I think it benefits patients a lot.
Definitely sounds like it. That sounds like one of the better options in my opinion, compared to conventional surgery that's not as minimally invasive. So thanks for explaining that, Dr. Monteith.
Sure.
So even with surgical treatment, are there any side effects?
Yes. So, with any surgery, there, unfortunately, there is going to be some pain. We can never completely eliminate the pain. And when you're talking about lung surgery, we're working on the chest. So when the pain is going to be pretty much anytime you take a deep breath or cough or those kinds of things. Generally, though, again, with minimally invasive techniques, the amount of pain that you have postoperatively and for how long is limited. I would say typically about a couple of weeks for my patients requiring prescription pain medication after surgery. So, but in terms of other limitations, one of the things we do as a preoperative assessment is to look at your underlying lung function and to see how you may do having a part of your lung taken out. And if those numbers don't look great, then we start talking about other options, non-surgical options. But even so, you can certainly expect when you take out part of the lung that you're going to have some shortness of breath, especially with exertion. But those are typical side effects of the surgery, but they don't last forever. As you get more active, your body adapts a lot quicker, and before you know it, you're probably going to be back at where you were before surgery. We'll never be able to make you breathe better by taking that part of your lung, but at least for most of our patients, we get them back to how they were before surgery.
That's good. That sounds good to me. So how is care coordinated between the different treatment types?
Yeah, so I kind of touched on that earlier, that more and more evidence is pointing to what we call multimodality care, meaning involving all the different cancer specialties. And at MedStar, we do what we call a tumor board, which is a meeting every week where we all get together. It's thoracic surgeons like myself, medical oncologists, radiation oncologists, pulmonologists, and radiologists, and then special pulmonologists called interventional pulmonology that do other kinds of procedures. And we all get together and we actually discuss, what is the best treatment for the individual patient. And then, once we do have that discussion, then, we go back to the patient and, we discuss their treatment options. The other advantage is, of having a cancer center is that we're all in the same building. And so it's very easy. It's kind of like a one-stop shop. So patients can get between the different specialties very quickly, very easily. And I have to say at MedStar, the communication between the different specialties is really what makes us special. We're constantly going back and forth in terms of what we feel is going to be the best treatment for the patient. And I think in a lot of other institutions, unfortunately, there's a communication gap, meaning that the doctors don't talk to each other. And I think I've heard of that complaint from a lot of patients when they've gotten their care elsewhere, and they don't have to worry about that at MedStar.
Thanks for sharing that. I think it feels good. I was a loved one of a patient at MedStar Health who had lung cancer, and it was good to know that my dad, he had the whole team behind his back, on his case, looking at the best options for his treatment plan. So that I can relate to that. Being a relative of a person who had lung cancer, it's good to know that you have a team behind you for that extra support. It's just reassuring through what is a very difficult experience. So thank you, Dr. Monteith, for sharing that. We have a few more audience questions. So I just want to pull one for just a second for the group. This one comes from Mary, who's asking, can you do a biopsy on nodules that are smaller than 10 centimeters?
Well, it should probably means 10 millimeters, but
Okay.
yeah, 10
Okay.
centimeters it's pretty
Pretty
good.
big.
That's about 5 inches. So we certainly can do that. 10 millimeters, which is about a little bit less than half an inch, and which is the more common types of lung nodules that we are seeing nowadays through screening and other early detection methods. The biopsies are generally three ways to go about biopsying a nodule. There's what's done. There's what we call CT guided biopsy, which is done by specialists at Franklin Square called interventional radiologists, who use the CAT scan machine to guide a needle in from the outside into the nodule to get the biopsy. It's a same day procedure, very safe. The other way, if the nodule is kind of more central, then biopsy is done by a procedure called navigation bronchoscopy, where it's by a specialist called an interventional pulmonologist, where they go, which we offer here also, where we go down with a camera from the inside and actually find the nodule through special hardware, and it's pretty cool. It's almost like GPS, where it guides you to the nodule and you get a needle biopsy of it that way. And then the third option is where I'm involved, which is probably the more invasive option, where it's to actually going in surgically to take it out to find out what it is, what we call a wedge resection. So all those options are great, and having all that at your disposal, we can pretty much get 99.9% of nodules out there.
That's good to know. Thank you. Thank you very much, Dr. Monteith. And thank you, Mary, for asking that question. I have another one. This one comes from Susan, who's asking, what are the targeted drugs for adenocarcinoma of the lungs? I hope I pronounced that right. So adenocarcinoma of the lungs. Any targeted drugs for that?
Probably meant adenocarcinoma.
Adenocarcinoma.
There are, targeted therapies for lung cancer, and it depends on what we find on the cancer cells. We send them for molecular profiling. We check for certain mutations in the cancer cells, certain genomic alterations, fusions, and if we find the target, we give a medication which goes to that target. So there are different targets like EGFR, ALK fusion. Many of those targets are usually never smokers or light smokers. There's another mutation called KRAS, which is common in smokers, and that is found more frequently, and there is a new medication for that, but that is for stage 4. Other targeted therapies, they can be used for stage 4 and some higher risk earlier stages cancer like stage 2 and 3. If they have EGFR mutation, they can get treatment for that after the surgery. There are other different types of targeted therapies which targets different molecules, but they are not very common in lung cancer, but those were the most common ones.
Thank you, Dr. Mahatesh. And thank you for Susan for sharing your question with us and tuning in. So we'll take a little bit more time a little later for more of our audience questions, but at this time, I'd like to turn to Dr. Perry. So how is radiation used in treating lung cancer?
Yeah, so radiation therapy is used in several different ways to treat lung cancer. We are usually involved in most lung cancer treatment, except perhaps some of the early stage lung cancers that Dr. Mahatesh, Dr. Monteith mentioned earlier that only go to surgery. But more often than not, we do participate in treating all stages of lung cancer. In general, radiation therapy is directed at the tumor. So we point X-rays very specifically at the cancer over several days to several weeks, depending on the case. And those X-rays then damage the tumor stops growing and eventually dies. And this is often done in concert with a chemotherapy or an immunotherapy that Dr. Mahatesh would give to the patient.
Thank you. And are there different types of radiation therapy?
And there's several different types of radiation therapy. The main types are termed daily radiation treatment or external beam radiation treatment. These are typically photons or X-rays. They're a type of treatment where the patient comes, they'll lie on a treatment table for about 10 or 15 minutes a day, and X-rays are then pointed specifically at the tumor. So that's one of the main modalities that we use. Another type of radiation treatment, which I think we're going to get to, is cyberknife radiosurgery. This is a type of radiation therapy that's a bit more precise, specific to smaller tumors, where we give higher doses of radiation treatment very precisely to small targets in certain early stages of lung cancer.
Thank you. Yeah, you answered my next question about cyberknife and how it works. Would you like to share a little bit more about that process?
Sure. Yeah, so cyberknife is a robotic delivery system. It's a type of radiation therapy that's actually given by a robot. This robot is programmed to very specifically and precisely target small lesions. And by small, I mean generally a few centimeters in size, really anywhere in the body, but in specific to lung cancer. We use it to treat early stage lung cancers that perhaps are not able to have surgery. So if a patient is unable to have the tumor surgically removed, perhaps they can't tolerate anesthesia, or they're not healthy enough to undergo the surgery, the cyberknife will then be used to target these small lesions and treat these early stage lung cancers. And this type of treatment is a shorter course. So when we use a cyberknife, we're generally talking about 3 to 5 treatments. Each one might last about a half an hour. Patient lies on the treatment table, the robot moves around them and points X-rays at the lesions. The patients don't feel anything from this treatment. It's just like getting an X-ray. So no anesthesia is used. It's all entirely outpatient. Patients come as they are, lie on the treatment table, the robot delivers the treatment. And this technology is very sophisticated technology that allows us to actually treat these tumors as they move through the respiratory cycle. So as patients are breathing and the tumor might be moving in different locations in their lungs, the robot is following that tumor in real time as it moves through the respiratory cycle and just making sure that the radiation goes to the tumor itself and avoiding the normal tissues of the lung and the esophagus, the spinal cord, things that might be close to that tumor that we want to avoid. The robot allows us to avoid those and only point the radiation at the tumor itself.
That's really good. That sounds like a fascinating treatment. The fact that it can really specially target the cancer cells. So thank you for sharing, Dr. Perry. Along with radiation treatment, are there any side effects that people should look out for?
So there are side effects potentially with radiation treatment. Sometimes in more advanced stages of lung cancer, we're treating a larger area so that the radiation does come up against the esophagus, or we have to bring the radiation through the skin to get to the tumor. So there can be some side effects associated with that. We use the most up-to-date technology, treatment planning systems, and again, the cyberknife being one of them, to avoid those normal tissues as much as possible. So our goal for patients is to eliminate the tumor, but to minimize any of those radiation-related side effects by avoiding the normal tissues as much as we possibly can. So by avoiding those normal tissues, we do lessen the potential for side effects, and we also increase our ability to direct dose to the tumor. And particularly with our cyberknife radiosurgery, we're able to have very high rates of eliminating the disease and very high rates of cure in these patients that we're treating with these high specific doses of radiation.
Thank you. At this time, I'd like to answer a few more of our audience questions. So this next one comes from Nikki. Thank you, Nikki, for tuning in. They're asking, can the radiation robot be used for stage 4 cancer?
So the radiation robot, or the cyberknife robot, can be used in certain cases of stage 4 cancer. Now, stage 4 covers a couple different things, but oftentimes, especially in more recent years, the data has been supporting this, and we've been seeing improved outcomes with using radiosurgery to target lesions that may have spread outside of the lungs. For example, a lesion that may have gone to a bone, to the liver, to the brain. We're able to eliminate those lesions with radiosurgery. And what we found is, and what's very exciting about this, is when we treat those lesions, this treatment works in concert with some of the systemic therapies that are being given, like Dr. Mohabdish mentioned, these radiation treatments specifically targeting these lesions that may have spread elsewhere in the body seem to help along the systemic therapy. As it destroys the tumor, it presents certain parts of the tumor to the immune system, which is then being improved and targeted to these tumors by the therapies, immunotherapy and others that Dr. Mohabdish mentioned.
Thank you very much. I have another question. Let me scroll here. This one comes from Brent about screening. So they're asking, is there a screening standard for patients who were exposed to a high volume of secondhand smoke as a child or as an adult, and or through jobs or through other jobs, working in a restaurant industry, you know, where people may have been allowed to smoke in those areas? Is there a screening recommended for them?
So secondhand smoking or passive smoking increases the risk of lung cancer, but to a much less degree than active smoking. So they are not considered high-risk patients. So there is no current recommendations for screening. The only thing I can recommend just to pay attention to the symptoms we talked about. Cough, shortness of breath, weight loss, blood in sputum, chest pain, all those things are warning signs, but unfortunately we do not have any standard screening tool for those people. And the reason for that, when the risk is not very high, of course it is elevated, but not to the degree of active smoking. You do so many CAT scans, you will find things that you shouldn't otherwise be finding. And screening is not harmless. You can have false positive results, and which sometimes leads to unnecessary biopsies or unnecessary repeat scans and extra exposure to CT radiation.
All right, thank you very much, Dr. Mohabdish, and thank you, Brent, for sharing your question. At this time, I'd like to close and direct this question to Dr. Monteith. What message do you have for our viewers today?
Let me unmute. Still getting used to that. So 1 second. Yeah, so today lung cancer can be found early among individuals at high risk, mostly former and current smokers, through a low-dose CT scan. Individuals who are at high risk should be screened regularly. Screening helps find lung cancer at an early stage when treatment is most effective.
Absolutely. Thank you very much for driving that point home. A few points that I learned today: do not smoke. And if you are a smoker, please quit. There are smoking cessation programs out there available to help you. And early detection is key. Keep in mind, if you're eligible for lung screening and early detection is important. So thank you very much to all of you. That wraps up our broadcast for today. Thank you to Dr. Mohabdish, Dr. Monteith, and Dr. Perry for joining us today and sharing your expertise. And thank you to all of our viewers for tuning in and sharing your questions and comments with us. If you are interested in learning more about lung cancer and available screenings and treatments, or if you'd like to schedule an appointment with us, please call 443-777-1133. We're going to share that information in the comments as well. So thanks again for tuning in and have a great day.
Take care.